Twice a year, the college holds a health fair in coordination with Pohnpei Public Health Services and the nursing program at the college. At the health fair, people are screened for high blood pressure, diabetes, and often for vision difficulties. When you're screening a population for a condition such as high blood pressure or diabetes, you want to make sure that you identify everyone who has that condition. You don't want to miss somebody who's diabetic because the condition will get worse and you won't be treating them. You want to make sure that you identify everybody with the condition so you can treat them. If you miss somebody, that is, the test comes back negative, but they actually have diabetes, that would be a false negative. A false negative means they had the condition, but your test didn't catch it. That's not a good outcome when you're screening. You've missed somebody with the condition. One of the difficulties is, though, that if you try to keep your false negative rate low, a different problem arises. You will sometimes identify people as having the condition who don't. Those are called false positives. But in the world of screening, one actually is willing to tolerate a lot of false positives in order to keep the false negative rate low. That is, a test will over-identify the number of people with the condition, but it won't miss or should not miss too many people. Preferably, it should miss none, but that's not usual with the test. So we screen, but when we screen, we accept a high rate of false positive. We then tell people who test positive to follow up with a doctor and further testing. There are other tests like an A1C that can help give a better picture of what the person's blood sugar situation is. So screening, we tolerate a high false positive rate, but then on a second test, we'll look for a test that has a much lower rate of false positive and a higher rate the rate of making sure that it identifies the person as having the condition. So let's take a look at some data. Here I've made a little table. If they have the disease and the test is positive, that's the result you want. That's a true, good result. If they have the disease but the test comes back negative, that's a false negative. If they don't have the disease, they don't have diabetes in this case, but the test comes back positive, that would be a glucometer above 140 would be diabetes, and 100 to 140 on the glucometers we use at the college, that would be borderline diabetes. A false positive would be somebody indicating that they have diabetes when they don't. And again, a follow-up test will clear that up. And true negatives are the test is negative and they don't have diabetes. So there was 1,000 people tested at the health fair. And later follow-up tests showed that actually of the 1,000, 120 were actually diabetic. But during the health fair, on the day of the health fair, only 110 of those with the disease tested positive that were actually with diabetes. But 176 of the remaining 880 people also tested positive. Those are false positives. They are the 880 who were not diabetic. It's not very clear there, but that's the ones who are not diabetic. So we have 110 were tested positive, but the test missed 10 people. That was the false negatives. As for the people who don't have diabetes, 176 came back with positive glucometer test results. And 704 came back as being true negative. In the world of public health and medicine, there's two numbers basically. There's a number that we calculate: the sensitivity and the specificity. For screening, we want a high sensitivity. When we're wanting to rule out a disease, we want a high specificity. So usually we'll lead with a high sensitivity test in screening, and then those who are identified as having the condition or disease are sent to get further testing with a test that has high specificity. So let me show you how we calculate these. It's a formula. You can see a diagram here on the right. The sensitivity is the true positives divided by the false negatives plus the true positives. This formula will require a parenthesis. My true positives go on top. That's the 110. Divided by open parenthesis. And now I'm going to add the false negatives, that's these 10, plus the true positives, that's up there. They're together, the false negatives and true positives. And so this is a very sensitive test. At 92%, it's going to capture about 92% of the people who have the disease correctly. It's going to miss a little less than 9%. This test is being used as a screening test. The glucometer is used as a screening test, and it's quite sensitive, but it does have a high false positive rate. Let's calculate the specificity. That's on the right side of this diagram. The specificity is the on top is the true negatives. Those are these here. Those are the true negatives on the top, on the in the numerator, divided by open parenthesis those true negatives again. Those are these plus the false positives. That's up here. This grid here is referred to as a 2 by 2 square. So the specificity is 0.8, and that's lower than you might want to, if you're being confirmed for something as serious as diabetes. 80% specificity is kind of low. You'd prefer a test that's 95 to 99% specific. Those tests exist, and so there will be other tests used to confirm the screening result. But high sensitivity correctly identifies sick individuals, while high specificity usually correctly identifies healthy individuals. So when screening, we use a high sensitivity test, which results in a high false positive rate, but we get almost everybody who has the disease. To confirm the result, we'll go for a high specificity test, where we really a diagnostic test typically, where we will be able to confirm for sure that you have this particular illness. Of course, the downside of these, they actually have a high false negative rate, and that's of concern, but we'll be able to certainly rule in the disease if that high specificity test confirms it. Now in this example, I haven't shown a high specificity test, like an A1C type test that has high specificity. It's really good at confirming disease, but it's that's a more complex blood test. You're not going to do that at a table in front of the library. So this is a 2 by 2 grid. Adds up to a total of 1,000 people. Now, if you add all those numbers up, you'll see that's our total population we screened. We screened 1,000 people that day. You can run these functions just like this. So it's 1,000 people screened. And that's a bit of an introduction to sensitivity and specificity, which are two terms we use when talking about medical tests in the context both of screening and diagnosis. I hope this has been helpful for you, and I thank you for watching.